I like to always start off my talk about childhood glaucoma, which is my major clinical focus, with the perspective that until about 75 years ago, congenital glaucoma was a purely blinding disease, and most of the children in schools for the blind were blind because of either injury or congenital glaucoma, because it was a completely untreatable disease. What we're going to cover include definitions, a little bit about epidemiology and genetics, how the disease presents, the diagnosis and various ancillary testing that you might want to do, some of the differential diagnosis, because not all cloudy corneas or large corneas in childhood are the result of congenital glaucoma. And then we'll talk about how we treat the disease. And then depending on with the time we have, or if you have burning questions after the surgery, we can continue with this discussion a little bit. So it's important, only in the last 10 years or so has there been a uniform classification of the childhood glaucomas, because not all glaucoma in children is the same disease. And it turned out 10, 15 years ago that we recognized that we were in different countries, even different centers in different parts of the world, were describing cases with different terminology. So there was a consensus book, and you can actually download this from the World Glaucoma Association. We had a consensus meeting in 2013, so that's 10 years ago, in which we developed a standard classification for childhood glaucoma. I don't expect you to go through this, but the main thing is that it provides a diagnostic checklist, just like the checklist we talked about yesterday for looking at the optic nerve, for deciding whether or not a child has truly classified as having glaucoma, and then further subcategorizing it into the things that you see in red, glaucoma following cataract surgery, and we'll talk about that in a few minutes, but that's probably the most common form of glaucoma in children. Of the children that had cataract surgery by Dr. Frederick this week, and the colleagues here, we now think that about 50 to 60% of them will go on to develop glaucoma in the next 1 to 2 decades. So having cataract surgery, especially in early childhood, is a very profound risk factor for developing glaucoma later on. And one of the tragedies we see is the patients see better, family thinks everything's great, and then they come in having lost vision in one or both eyes 10, 15 years later. So primary congenital glaucoma is the rare form of glaucoma that shows up usually in the first year of life. Can you get some water for me? That'd be great. And we further classify it by the time of onset. And the reason we classify it by time of onset is the earlier the onset, thank you. The earlier the onset, the worse the prognosis. So a baby presenting with congenital glaucoma at birth or in the first 3 months has a much worse prognosis than a child who presents at 11 months or 18 months of age or even later. Juvenile open-angle glaucoma is pretty much indistinguishable from primary open-angle glaucoma in adults, except that it presents much, much earlier in the teens, 20s, or 30s. That's why I suspect that the patient that we operated on yesterday, who was 44, who already had bad glaucoma, that needed a trabeculectomy 10 years ago, probably should be classified as juvenile open-angle glaucoma. We now know some genes for this, and in the United States I would test for that. He didn't have a strong family history, but there were members of his family that did have glaucoma. So I suspect that was what was going on. And then just as in adults, you have all the secondary forms of glaucoma that can develop in childhood: uveitis, traumatic glaucoma, and so on. And then there are ocular abnormalities such as Peters anomaly, systemic things like aniridia, Sturge-Weber, and so on. Primary congenital glaucoma is a rare disease. but it's rare primarily in the United States. In parts of Africa, it's actually quite common. I've worked with some colleagues in Ghana, and they see an enormous amount of childhood glaucoma. Obviously, they're at a referral center for the country, but it really varies from place to place. The most impressive rate that I've seen has been in Saudi Arabia, where the Kekesh Hospital, when I was there, they were seeing 1 or 2 new cases a day. And the reason for that is because it's a very tight-knit group, and there's often a lot of consanguineous marriages, so the genes responsible for congenital glaucoma are amplified in these close-knit groups that marry within closely related families. As I mentioned, glaucoma following cataract surgery is much more common than we realize. The IAT study was a study looking at leaving children aphakic versus putting in a lens. So contact lens versus lens implant, trying to decide which is the better management for congenital cataracts. And a group of folks developed that classification scheme and monitored things. And at 1 year of follow-up, already 14% or so, 15% or so of the children had developed glaucoma or significant ocular hypertension. We now have 5-year results. I've seen the 10-year results, and the trend is continuing. So the lifetime risk of a child who had cataract surgery in the first few years of life is quite significant for developing glaucoma. And you need to really educate the families that these children need to be monitored at least once a year by somebody who's paying attention to the risk of glaucoma. And here you can see some of the Kaplan-Meier curves. And these trends, I've seen the 10-year data. It's not been published yet, I believe. But this trend continues. And if you continue the trend, it's looking like 50 to 60% of children who have cataract surgery in the first few years of life will go on to develop glaucoma in the first decade or two after surgery. The genetics of glaucoma are very interesting in children. Let me give you a little bit of nomenclature when we talk about the different genes. The GLC is the documentation or the nomenclature for a gene that's thought to be responsible for glaucoma. So GLC1 is open-angle glaucoma, GLC3 is for angle closer, and 3 is for congenital glaucoma. So a GLC3 gene is a congenital glaucoma gene, and then A, B, C, D, and so on in order of discovery. So the first major gene discovered for childhood glaucoma was GLC3A, and that is that's just naming or listing the genes. What the gene codes for is cytochrome P450, and it's called CYP1B1. That's what we use to say, oh, this is a CYP1B1 autosomal recessive mutation or whatever. And what's really interesting is that there is enormous variation around the world for how they present. In some places, similar mutations probably interact with other mutations present in the families or in that area of the world to change how it is phenotypically expressed. So this can cause severe disease in infants, but even within a single family, you can see quite a bit of different variation. Arif Khan published this nice family tree just showing they all had the same mutation, and yet you can see how severe or how variable the presentation of these children and young adults can be. Most of the cases are sporadic. Again, these are the take-home points. Increased prevalence in populations where there's a great deal of consanguinity. And genetic testing, and I'm starting to do this more and more as the cost of testing has gone down. So if I see a child who has congenital glaucoma, I start talking to the family. Are you guys planning on having other children? And the reason to consider doing genetic testing and understanding what the mutation is in the child, you can then, when the baby is born, even if they don't have signs of glaucoma, when the second baby is born, you can see if they have the same mutation. And that gives you an idea of whether or not they're likely to develop glaucoma over the next few years. If they don't have the mutation, their risk is no higher than anybody else, and the family and everybody can breathe easily. Congenital glaucoma presents in a myriad ways, but the typical finding of these are some children that I've taken care of over the years. This one you've actually seen. He's now, I think, 18 or so. Typically a large cornea, swelling of the cornea, corneal edema, ocular enlargement, tearing, photophobia, and blepharospasm in terms of the children avoiding light. Dr. Chisi, you were with me the other day, and remember the boy that we ended up doing the CPC on? I mean, he would not open his eyes. And it wasn't just, it was really photophobia, because when we turned the room lights down, he opened his eyes. And the next day, I was amazed that he was just walking in with his eyes open. So, you know, clearly there's something about pressure that just causes severe photophobia. This gives you an idea of how children present. If they're present in the first 3 months of age, it's usually a bilateral disease. In my experience and in the literature, it's usually, you know, it may be asymmetric, but it's usually obvious in a young child that it's present in both eyes. After about 3 months of age, about a third of the patients just have unilateral disease, after 3 months, and it's more males than females. Also, from the corneal standpoint, the usual presentation in infancy is a hazy cornea. Later on, it's just a large cornea, and in between the two, it's both. There's a large differential diagnosis of where do we go here? Of corneal clouding in infancy. So you need to think about whether or not, if it's bilateral and the patient has no other problems, you know, is this an inherited corneal dystrophy? But those are usually obvious. But in congenital glaucoma, what's happening is that the eye is distending, and the Descemet's membrane underneath the endothelium is basically snapping and ripping due to the pressure. And when it rips, the eye becomes acutely cloudy. And I apologize, I do have a good video, and I forgot to put it on my laptop to drop into this presentation. But a patient of mine, these days, every parent has a smartphone and is taking pictures of their kids at least 20 times a day. And I did have a patient of mine have her video when the cornea became acutely cloudy in her child. So we actually caught the moment that happened. And I saw the child, you know, a few days later, and the corneal swelling had gone away. So when you talk to your pediatric colleagues, and they, and I'll show you an example of this, and they see the mother says the cornea was cloudy or the eye was cloudy, and they see them in the office 2 or 3 days later, and the pediatrician doesn't see anything, and they say, well, I don't know, they'll grow out of it. But that's a real warning sign, and encourage people to look at the pictures, because moms often take pictures, as I'll show you. This is one of the more extreme examples. This was hydrops at birth that I dealt with. You've seen this patient. She's now 20-something. And her sister presented in exactly the same way a year later with the eyes in the opposite. But they're both doing marginally well, but they had very, very severe disease. They both lost the eyes that had acute eye drops. Those were not salvageable. History is really important. And as I just said, the parents may report an earlier episode of the child becoming fussy, the eye becoming cloudy, and when you see the child, it's not obvious that there's a problem. And as I said, the pediatricians often will dismiss this as just nothing. But again, here's an example. This was a child that I saw a number of years ago. She was 3 months old, and we get the outside emergency room physician calling and saying she has a white cornea. I think it might be an ulcer. Should I start Tobradex? And that's wrong for so many reasons by an emergency room physician wanting to start an antibiotic and a steroid in a corneal ulcer. But this is what she looked like a few days later. But mom had taken photographs through the day before this happened. So here it was on the 1st of May at 4:35, and the beauty of this is the phone stamps the time on the picture. So here you can see at 5:37. So she had a pretty clear cornea at 4:35. And then if you look here, it zooms in, and you can see that her cornea is starting to get cloudy. And then here she is when she's putting her back in the car seat to go back home, and you can see that the cornea is getting cloudy. And then in the emergency room at 3 in the morning, you can see that cornea is cloudy. So you can see this evolve. And then she comes and sees me the next day, and you saw the photographs here, but she has this diffuse edema. But look at this. This is a day later, and the cornea has cleared. So this is why this finding of a cloudy cornea that comes and goes is really, really important. And many of the children that we saw here have multiple different haubstria, and they probably had multiple episodes like this that mom or the pediatrician have dismissed as nothing serious, but it truly is. And you can see, this is just an iPhone photo that I took in the operating room, and you can actually see the break in Decimase membrane right there. And the endothelium has repopulated it and pumped the cornea dry, so it clears again. Long term, this child has done very well, and she actually is a patient of mine. And when this Flying Eye Hospital visited Sacramento in 2016, this is her and her mom in the operating room, and we got a little picture of her sitting in the cockpit up front that you just saw. And she's doing very, very well. She's, I think, 14 or something now. Okay, so there's a large differential diagnosis of cloudy corneas, CHED, various polysaccharidoses, and all these things listed here. But the difference between these things is it's usually not evident at birth. It takes a while to happen, but it's usually very symmetric. There's usually a family history, and every other aspect of the eye exam is normal. So those are things that really need to be sent to a cornea specialist to look at. If you have to do an exam under anesthesia, you can do it, but it's probably not an emergency. Birth trauma. Here in Zambia, are many children born with forceps, or most people go straight to a C-section now? Do you have a sense of that here? Do you have a sense of it?
If it's a complicated case, they would use a vacuum.
Oh, they do vacuum extraction. Yeah. Okay. So in the days when people used forceps, if the forceps unfortunately pressed on the eye, it could cause a break in Decimase membrane. And I have had a couple of cases where that was the question. But in the interest, I can show you some pictures of that. I can probably find them on my laptop. But this is a typical sort of straight Decimase break from a forceps injury. But again, that you usually have a history of a birth trauma. The cornea was cloudy at birth and then became clear. The hallmark of glaucoma under the age of 2 or 3 is that the eye just stretches over time because of the high pressure, like a balloon. The collagen that makes up your sclera and cornea is not fully cross-linked, and so it just stretches. And all portions of the globe tend to stretch in response to the elevated pressure, so the axial length increases. That's why we always measure the axial length during every examination under anesthesia to get a sense of whether or not the eye is continuing to expand related to treatment. The corneal diameter increases. That's why we measure the corneal diameter. One of the children we saw and did an EUA on, I think on Wednesday, had an axial length of almost 29 millimeters and a corneal diameter of 15 millimeters. So these are enormous eyes. And the optic nerve becomes cupped. And with successful treatment, as I'll show you, you can see reversal of the cupping. That doesn't mean that neural tissue that has died is regenerated, but the structure of the nerve tends to shrink down and become less cupped. The normal corneal diameter of a newborn full-term neonate is between 10 and 10.5 millimeters, and it increases about 0.5 to 1 millimeters of mercury during the first year or so of life to reach the adult size of about 12 to 12.5 millimeters white to white in the average adult. So if you see a child where there's asymmetric corneal diameter, that's something that is of certain concern. So anything where you see a asymmetry of more than a millimeter or so is always of concern. In the differential diagnosis of large corneas includes megalocornea, which is an X-linked syndrome, along with a microphthalmic fellow eye. A couple of times in my career, I've had children referred to me for asymmetric eyes, and the referring doctor thought the larger eye was the abnormal eye, but it turned out that the larger eye was totally normal and had a normal corneal diameter, but the other eye, for example, would have a coloboma or something like that, that meant that the eye was somewhat smaller, and that was the abnormal eye. So that's both good news and bad news. It means that the child's probably more or less going to be monocular, but the good eye has nothing of concern, which is good for the family. Epiphora is such a non-distinct or symptom. I don't really pay a lot of attention to it as a presenting sign, but the whole pattern of photophobia and large cornea, epiphora, and so on are useful in understanding this. So the diagnosis of glaucoma in infants and children is clinical. With ocular enlargement, a cloudy cornea that may be waxing and waning, elevated pressures, and we'll talk about how to measure pressures, optic nerve cupping, and then key to the diagnosis is gonioscopy, which obviously you can't do in the office, but during an examination under anesthesia. The cup to disc ratio in infants that has been looked at since the 60s is about less than 0.3 so it's greater than 0.3 in only 2 or 3% of newborns. So if you look in at a child and you see a 0.6 cup, that's something you need to be concerned about in a young infant, because that is not normal. It may not be glaucoma. They may have megalopapilla. They may have other things. But that's very suspicious for glaucoma, and you need to look at the whole picture. Pressure measurement in children is usually in the low teens. It depends on how you measure it. An office measurement of greater than 20 is certainly very suspicious for childhood glaucoma. But it's important to understand that, that no tonometer is particularly accurate in young children. There are many, many artifacts involved in measuring pressure in children, not the least of which is them crying and screaming and so on. I mean, I give up if the child starts fighting me and screaming and whatever, because I know I'm going to get a high pressure, but I'm not going to know why what the high pressure is, whether the high pressure is real or not. I do not use, I understand here that it's not uncommon to use the Schiot's tonometer in children. I would advise against that. The Schiot's tonometer makes a number of assumptions about scleral rigidity that do not apply in a child, in a pediatric eye. And so it's going to read all over the place. And in much of the world, the Schiot's tonometer has been abandoned for a number of reasons, not the least of which is keeping it sterile and clean, but also in childhood glaucoma, it's known to be highly inaccurate, so I would not recommend doing that. So the important take-home point about pressure measurement in children is that it is often the least useful piece of information in terms of making the diagnosis of glaucoma in children. So to summarize thus far, do you want to take that picture? Here you go ahead. So the summary thus far is that in children, glaucoma usually presents with ocular enlargement and corneal edema. And when you see a child like this, you want to get a family history, an obstetric history in case you're in an area where forceps delivery are performed. And you can get reasonably accurate pressure measurements, especially in the very young baby, if the baby has fallen asleep right after nursing or something like that. What I often encourage the families of children when they're coming back to me, if I wasn't able to do an exam and I don't have to do an exam, I'm not so worried that I need to do an exam under anesthesia, I'll often tell the parents to, when you come back next week or the week after, withhold food for a few hours before they come in. And then when we get into the room just before I come and see them, feed them. And they will just be so, they will have been crying and hungry, and then you feed them, and they fall into a very deep sleep. And you can usually get a pretty good exam when you do that. But if you just walk in like a bull in a china shop and just try to get in their face and measure a pressure, you're just going to get useless numbers. So there are tricks to examining young infants. So let's talk about the clinical management. If the cornea is clear and the suspicion of glaucoma is relatively low, I would just repeat the exam in a few weeks. I would not subject a child to the risks of anesthesia, the hassles of anesthesia, and repeat this in a few weeks. And again, that trick of just timing the exam during a nap or shortly after feeding. If the cornea is clear and the suspicion of glaucoma is high, you need to schedule an EUA and plan on, if possible, doing the surgery at that exam under anesthesia. If the cornea is cloudy, I would schedule the EUA and I will usually start some medications. Now, it's important to recognize that in a young child, putting timolol in twice a day is a very high systemic dose of a beta blocker, and you can start getting into trouble. Think about this. The eye of a child is about 75% the size of an adult eye. Eye drops are designed to reach a sufficient concentration in the tear film to be absorbed into the eye. And yet most of the eye drop goes down the nose and is absorbed systemically. And so, a 50 microliter eye drop in a 70 kilogram adult is really of no significance. But in a 3.5 kilogram neonate, that's a huge dose, and it reaches toxic levels pretty quickly. So you really need to think about being very careful on using medications that have systemic effects. And I hope that all of you know that brimonidine is absolutely contraindicated in children because it is a profound CNS depressant and can cause apnea and somnolence in young children. So I don't know if you know the terminology black box warning, but this is something on the prescription or the instructions to doctors from our Food and Drug Administration. When there's a black box warning, that means beware, this is a serious potential complication of this drug. And there's a black box warning on using brimonidine in children. Iopidine, if you have access to that, apraclonidine, is safe to use in children, and the reason for that is it does not cross the blood-brain barrier, whereas brimonidine does cross the blood-brain barrier. We use medical treatment only to temporarily lower the pressure and not as a primary treatment. I will use low-dose beta blockers. I don't know if you have formulations that are 0.25%. You could probably make something up and dilute it. You can use carbonic anhydrase inhibitors. We'll sometimes have the pharmacy make up an oral solution of acetazolamide if you needed to. It's about 5 to 10 milligrams per kilogram. And if you have a pharmacy that you work with where they mix up like oral antibiotics, amoxicillin or so on, instead of putting the antibiotic powder in the amoxicillin bottle, they can take the injectable form of acetazolamide and make the concentration appropriate so that it's an appropriate dose twice a day or so on in a liquid that the mom can squirt 5 milliliters into the baby's mouth. I don't generally use the prostaglandin inhibitors in young children. They work sometimes, they don't work other times. I just find them to be very unpredictable. So, although the diagnosis in the office is usually pretty obvious, we need to do an examination under anesthesia to classify the type of glaucoma and better understand what the next step is going to be. And the other thing that I would emphasize is that this is not a decision that should be taken lightly, okay? Anesthesia is not benign. I've seen kids almost die during what I thought was going to be a routine examination under anesthesia. Luckily, we have superb pediatric anesthesia at my institution. Other places are not so lucky, but I had one child who's now a healthy and normal intelligence 32-year-old now, but he had a cardiac arrest during an EUA. And that is one of the scariest events in the operating room I've ever experienced, and it really drove home to me that we just don't say, oh, let's just do an examination under anesthesia. It can have potentially life or death consequences for children. So we just don't do an examination under anesthesia unless we're going to make a decision and actually be prepared to do the surgery at the time that we do the EUA. What drives me nuts is when patients get an EUA by an outside doctor to, quote, confirm the diagnosis of glaucoma and then send it to me for the surgery. If you're not prepared to do the surgery during the same anesthesia, you shouldn't be doing an EUA. Most of the inhaled anesthetics lower the pressure pretty rapidly. Ketamine is used in different places. I really like having the children get a large pre-medication of a benzodiazepine like Valium or Versed or whatever. And our institution, they often will squirt a little Versed in the child's nose or give them a little Versed in a sweet solution about 10 minutes, 20 minutes before they come back to the operating room. We know that benzodiazepines don't seem to affect intraocular pressure, and the children come back to the operating room giggling or falling asleep or whatever, and I can sneak in and measure a pressure without them fussing, and that's actually the most accurate pressure that I can get before we actually intubate them and put them to sleep. At the initial examination under anesthesia, I want to get a pressure measurement either in the way I just described or when they mask the child down, when they do a mask induction, I will sneak in and just check the pressure. The last thing you want to do is be waiting in the T room and then say, okay, the baby's in the room, they're intubated and asleep, and we've lost the opportunity to measure intraocular pressure accurately. So I like to be there, and the policy at my place for an EUA is I am there when the child is brought into the room, and I instruct the anesthesia team that as soon as the child stops moving while you mask them down, I sneak in and check the pressure. I have them take the mask off because in a baby, the pressure of pushing down on the mask is transmitted to the eye. It's one fluid column. And so if they're mashing down to keep an airway on, that, the pressure is going to be high, and I have no idea what I'm measuring. I get axial lengths, corneal diameters. I look at the optic nerve. I'm lucky enough to have cameras that can take photographs of the optic nerves that I do at every exam, and also gonioscopy. I also get corneal pachymetry just to understand over time what's happening to the cornea. And I will usually do a retinoscopy at the time. And then if you do not have a view of the back of the eye, you must do a B scan. And I say this from experience because over the last 3 decades, I've had 2 children present as presumed congenital glaucoma. I went to the operating room thinking it was congenital glaucoma, and we did a B scan, and it was bilateral retinoblastomas. And so it is not a good day when you go to the exam under anesthesia and plan on doing glaucoma surgery, and then you come out and have to tell the parents that the child has cancer of both eyes. That's not a fun day for anybody. So I'd rather know that in the office. So now when I see a new patient in the office, unless I can dilate them in the office and get a view, I get a B scan in the office just to make sure I'm not missing something. It's rare, but it really does happen. We get the axial length because there are some nomograms, as you can see here, that show the normal growth curve of axial length. And you'll often see the growth curve of a child with glaucoma go way, way up. And then once you stabilize the pressure, it will start coming down or at least parallel the growth curve that is normal. So it may go up like this and be up here when you first see the child, but rather than just continuing along this arc, if you're successfully treated, it'll sometimes go like this. It'll probably be larger than normal, but at least the increase will stop. And that's one of the hallmarks of successfully having treated these children. So the next part of the exam under anesthesia is to do a gonioscopy. I don't generally use the Kepi lens unless I'm going to try to photograph things. But the anterior chamber angle is very apparent, and it has a very anterior iris insertion, a very hypoplastic peripheral angle iris insertion. And Dr. Cheesy, you saw earlier when we did the goniotomy on the child, I incised right along there, and it just started to peel back when we did the goniotomy. And the angle surgery, like a goniotomy, is the preferred procedure. And I hesitate to say that it can cure the disease, but in some cases it actually can. I have had some people present with congenital glaucoma where we did angle surgery, and they're disease-free into their 20s. So it's an amazingly specific procedure that can fix the problem. The treatment of glaucoma is surgical. Angle surgery is highly successful in these children if it properly selected children. And also the medical treatment is useful only for temporizing and waiting for surgery. It's not particularly useful for long-term care. Parents may have trouble paying for the drugs. They're going to forget. The kids fights them, so they just give up on making the children take their the drops and so on. And in the 1930s, this gentleman, Otto Barkan, presented 10-month data. He was the one who realized that the trabecular meshwork was where the problem was in most forms of glaucoma. And he had the insight to develop gonioscopic lenses that could be sterilized make an incision into the anterior chamber, and visualize what you were doing, rather than what was done in the 1890s by an ophthalmologist in Italy, who basically stuck a needle in and waved it around and probably blinded more patients than he helped. Goniotomy requires really good visualization of the angle, and we also do an external approach to do the same procedure called trabeculotomy, and which I'll describe in a moment, because not every cornea is clear enough to be able to see what you're doing in the angle. So as I said, if you're taking a child to the operating room to do an exam under anesthesia, you should be prepared to do one of 3 or 4 different types of procedures. You shouldn't go in there, subject a child to an anesthetic where you only have one operation in your toolkit, because we'll make the decision often on the table in the operating room of what procedure we're going to do based on what we find under the microscope. So this is what a goniotomy looks like. And with this procedure, you can usually treat about 120 degrees. It involves a small incision. This is the original lens that Dr. Barkan used when I started. This is what we had. So I have some of these nice photographs of how this was done, and this was an old goniotomy knife going across under direct visualization. This is a video a few years old. I need to update it, but so this child had an exam under anesthesia, had a reasonably clear cornea. I knew I wanted to do a goniotomy. I dilate most of the patients unless there's a contraindication so that I can take photographs of the optic nerve and make sure I'm not missing any other retinal pathology. So I put in a miotic, and then I filled the eye with viscoelastic. Some people put like a Lewicki, an infusion cannula to maintain the anterior chamber. I prefer to use a viscoelastic. This is a Swan Jacob lens. This is the Grieshaber knife that I used to use. And so here you can see it going in. And I'm doing this while looking through the microscope, through that mirror, and you'll see in a moment what I am doing. And so here is my view as a surgeon putting this in. You want to make sure that you don't hit the lens. The last thing you want to do is not be paying attention and violate the capsule. That becomes a whole other problem. And let's see if the focus gets better. If we have time, I have a recent case that we did a couple of weeks ago that we got some pretty high-def video. And here you can see, as I start to cut anteriorly, you can see that the iris is starting to fall back. And usually you'll see some bleeding come back from the collector channels. We saw that on Tuesday. When we did that, you can see the punctate areas of blood refluxing. And that's a very reassuring sign, because that means that the collector channel system is intact. In some children, we now recognize a number of mutations in which the collector channels are abnormal or absent, something called the TEC mutation, which is a mutation in the angiopoietin gene. That's only been recently recognized, but in those children, it may be futile to try angle surgery, because you're trying to open the trabecular meshwork to give the aqueous humor access to the outflow channels. But if the outflow channels don't exist, there's no point in doing that. And so over the next decade or so, we'll probably be doing rapid genetic testing prior to taking these children to the operating room to further define what is the best operation for a given child. This is an example of what an eye will look like after goniotomy. This one's a little messy, but you can see over here that the angle has fallen back, whereas on the right is the typical appearance of what an angle will look like in a child who has congenital glaucoma. As you saw, trabeculotomy or goniotomy requires a clear cornea with good visualization of the angle structures. And in the 1960s, a group in the UK, as well as a group in Germany and a group in Iowa, each independently developed techniques for how to do this in a child who had cloudy corneas where you could not see. This is a case that I did early on. This shows the Kepi lens, and you can actually see I've cannulated the beginning of the optic nerve, the beginning of the canal with a black piece of nylon. So I know that I'm in the canal and you can actually see it. And we insert this metal device called a trabeculotome, and we sweep inside. So this is called a trabeculotomy ab externo. The Latin ab means from. So goniotomy is an ab interno, from the inside procedure, whereas ab externo means from the outside. So this is how a trabeculotomy was done. In the 1990s or 80s, 90s, Mary Lynch and Alan Beck introduced an approach in which they fed a suture in 180 degrees and retrieved it from an incision on the opposite side, and then they went the opposite direction and basically cheese wired it and pulled it. This is a case of mine, again, is low def, because I don't do this much anymore. So this is before we had high def video in our operating rooms. But here you can see inserting, so I've identified and unroofed the canal, and you can now feed with very little resistance a 5/0, I think, nylon suture, and it goes in with relatively little resistance. You can see how cloudy the cornea is. There's no way I would have been able to do an ab interno approach. And again, another reason to want to be prepared to do a number of things and change your plan was a good example on Tuesday. I went in there expecting to do a tube, a glaucoma drainage device in the child, but while we were sitting there and under the influence of the anesthesia that dropped the child's pressure, I was sitting there looking and saying, the cornea is now getting clear enough for me to do a goniotomy. So we ended up switching to doing a goniotomy because as the pressure was lowered during the anesthesia, I felt we finally had a good enough view to be able to do the goniotomy, which is preferable than to putting a large piece of hardware in a child's eye. So here you can see we're feeding polypropylene. This is a Prolene suture. And I don't know if I can speed this up, but you get the idea here. And I now retrieve it from the opposite side. And then we can do the same thing over here in the opposite direction. And once we're done, just go back here. All right, let me just show you this. Go away. And so here you can see that we're retrieving the suture. This takes a lot of practice, but it's very low tech. It doesn't require anything more than what you would do with a trabeculectomy with sutures and creating a flap and using a suture. So it's a very cost-effective way. And here in Zambia, whether it's Dr. Munga or somebody else, if they develop the skill, and it takes a lot of practice to do this. This is not for the faint-hearted, but it's still a very effective and cost-effective procedure. This is what we do at our institution now. It's expensive because the device that you'll see here costs, it's a consumable that costs anywhere from $800 to $1,000, so it's not sustainable in much of the world. But here I'm identifying the canal. and the side-to-side maneuver. But here you can see this little threaded cannula that has a blinking light at the end. It's a fiber optic probe. And once you get it in place, you can feed it all the way around. And you can follow it as you go. Next time we do one of these, Sina, we should get one of the OR staff to use my iPhone to get a high def external video of that. Yeah.
Do you prefer a goniotomy to a trabeculotomy?
I prefer an ab interno trabecular. I don't do goniotomies that often anymore. I will sometimes do a touch-up goniotomy if it worked for a while and then failed. But what I do now is something called GAT, which I'll show you in a moment. But here you can see the light is coming around. Again, I should speed up this video and edit it for speed, but in the interest of time, how soon is your case going to go? Are they? It was a no-show? Oh, I'm sorry. All right, so we'll do a lot of lectures today, and it'll be worthwhile. Okay. Whoop, I exited. That was a mistake. Here, let's go. So we've retrieved the device, and here you can see that I'm grabbing both of them. The eye is filled with viscoelastic. And you can, if you understand the anatomy here, what I've done is I've torn open the trabecular meshwork and the canal of Schlemm 360 degrees. And this is what it'll often look at, and everyone will go, oh my God, what's going on here? But as you may have seen in the note at the bottom, the hyphema was completely gone the next day, and the pressure was 9. So, you know, the blood has to have gone somewhere, and what we essentially did was open up the entire canal. And that child, if I remember who it is correctly, is now in her teens, and, you know, she's on no medications, and she's doing just fine. So it's an amazing procedure. Damage, you know, complications of these procedures include damage to the lens, not properly identifying the structures of the anterior chamber angle in children. Gonioscopy in children is not the same as gonioscopy in adults. Often there's very little, if any, pigment in the angle, so there are other tricks to identifying things. As I showed to Dr. Chisi and Dr. Munga on Tuesday, sometimes if the angle structures are a little indistinct, what you can do is decompress the eye a little bit when you first make a paracentesis, and usually there's blood reflux into the canal, and then when you reform the anterior chamber with viscoelastic and you look at the gonioprism again, you see the blood in the canal basically shows you the way, shows you exactly where you need to do your goniotomy. It's a very nice trick. Some people are using ICG and trypan blue, but I find the best thing to do is just decompress the eye, allow some reflux, and then see it. You'll get a small hyphema in almost everybody with a goniotomy, and you can get corneal endothelial damage. With trabeculotomy, you can get stripping of Descemet's membrane, damage to the lens. You can get iridodialysis, and if you don't close the scleral flap properly, you can end up with a bleb, which is not the end of the world, except that I like to do my surgery from a temporal side, just from the ergonomic standpoint, and it is not advisable to have a filtering bleb temporally in a child, because that's going to get infected. There have been some studies looking at goniotomy versus trabeculotomy. They're essentially the same operation from a different approach, and there does not appear to be any significant difference in outcomes between the two. So, as I said, I prefer to do ab interno procedures where I spare the conjunctiva, leaving the conjunctiva for other procedures if necessary. But but in any case, my preference these days is to do a ab interno procedure. Determining success is often, we can measure the pressure, we can look at axial shortening, we can look at refractive error shift. There's usually, if you've shortened the eye, you'll see a hyperopic shift in the child's refraction, as well as cupping reversal. And again, as I said earlier, IOP is often the least reliable way to determine whether the procedure has been successful. Here are some examples of, this was what I forgot I had this slide here, but here is a successfully treated eye that is returning to the normal growth curve, whereas this child, their glaucoma has continued to get worse despite treatment. As I said, we take photographs of optic nerves at every exam under anesthesia, and in 2011 we published our results showing, and these are examples, look at this. This is pre-surgery, this is post-surgery, pre-surgery and post-surgery in the same patient with bilateral disease. So this is what cupping reversal looks like when you successfully treat these children. And we published this in a whole series of children of successful and non-reversal groups. So if angle surgery fails, then what do? We will sometimes do trabeculectomy. My preference generally is to do tube shunts. Usually the Barvelt or the Ahmed, I don't do the Maltino implant anymore. For those of you who have ever done Maltinos, Tony Maltino, who launched the concept of this, passed away 2 weeks ago in New Zealand, but he was a real innovator in our field. The advantages and disadvantages of trabeculectomy are that it's technically easier than the other procedures if you don't do them very often. But the caveat is that creating a scleral flap in a buphthalmic eye with very thin sclera can be very challenging, so you need to feel very comfortable creating scleral flaps. But the other advantage is that most ophthalmologists perform trabeculectomies and have the instruments. It doesn't need any specific tools or consumables. But obviously you have limited ability to adjust things like cutting sutures and so on without taking a child back to the operating room. A glaucoma drainage device have their advantages and disadvantages. That's a whole separate topic. I certainly do plenty of tubes in children, but they're often close to my last resort. The last resort that we will do in these children is cyclodestruction. I don't think the teaching hospital has a cyclophotocoagulation laser, but this is something that I will do. But I'm very careful about doing it because I have a child that Dr. Vahedi and I operated on recently, who's now, how old is he, 14 or 17? I think he's quite old, he's mid-teens. But he developed, I'll cut to the chase here. He presented in England to a pediatric ophthalmologist at 3 months of age, and it turned out the child had Coates disease in one eye, and that ophthalmologist did retinal laser, and the child was lost to follow-up for 6 months, and then came back with a painful eye, and they had neovascular glaucoma, and the doctor there did cyclophotocoagulation in the eye with neovascular glaucoma, which in most situations is not unreasonable. And then the child, who was the child of a U.S. Air Force member who was transferred back to the United States near me, and I saw the child. So I saw the child, and he had a Tysical eye with the eye with the Coates disease, and inflammation in the other eye. And essentially, it's the only time I've ever done a diagnostic enucleation in the operating room during an exam under anesthesia, because I thought this child had sympathetic ophthalmia, and we confirmed it. We could actually see thickened choroid and long term, he's aphakic, having undergone 2 penetrating keratoplasties, and we recently hooked up a second Barvelt implant. He still has good vision, and his nerve is not terrible. But if they had not done the CPC, he would have grown up with a totally normal eye. This is the pathology. We're about to publish the long-term results of this with the pathology, so we want people to warn. So the take-home point for this is I will not do cyclodestructive procedure in a child whose other eye is otherwise healthy or has a reasonably good prognosis of being that child's sighted eye for the rest of their life, because I do not want to do anything in an eye that is so poor prognosis or is blind that would put the other eye to risk. We did a bilateral CPC the other day, and I guess there's a rare risk that we could create bilateral sympathetic by having done that, but the child's almost blind anyway, and it was sort of let's try something to get the pressure down. Here are the Dalen-Fuchs nodules. I mean, amazing pathology, and we ended up doing a trabeculectomy, so I got an iridectomy specimen in the other eye, and we could show that this was bilateral sympathetic. Let's see. This is him. I obscured his face, but he and his family have a sense of humor about it. So he has the T-shirt that says "Depth perception is overrated," because he only has the one eye. All right, let's talk about some of the systemic associations in childhood glaucoma. I guess we're not constrained to a 1-hour thing. I'll talk about this for a little while. Do you have a talk that you're going to give, or? Yeah, maybe we can alternate, flip it. Yeah, okay. So I need to catch. I'm going to lose my voice if I keep talking continuously for 3 hours. So some of the things that you will see, these are all things that are associated with either systemic or local ocular problems. And the two that you should know about that you will almost certainly see here include Sturge-Weber syndrome and its variants, as well as aniridia. So let's focus on those. Sturge-Weber is, I'm sure, familiar to you, and it's a triad for the full syndrome of port wine stains, glaucoma on the side of the port wine stain, and intracranial involvement with hemangiomas that you can see as cranial calcification, intracranial calcifications. And the glaucoma can arise from 2 different mechanisms. One is that you can have elevated episcleral venous pressure, so the eye is trying to pump fluid out against a much higher episcleral venous pressure. And there's also some forms of this, particularly presenting in infancy, in which the angle looks indistinguishable from primary congenital glaucoma. And there even have been some reports showing that in some of the Sturge-Weber patients, they have the CYP1B1 mutation as well. Unclear why that happens, because they're both extremely rare diseases, and Sturge-Weber is not an inherited disease. It's a somatic mutation. This is a child, you can see the midline involvement, although this child has some port wine stains on the upper lid there. And this is what the conjunctiva and the episclera looks like when you take the conjunctiva down to do a procedure. I think I ended up doing a trabeculotomy in this child, and that's why you can see here what this looks like. And one of the more satisfying things is to take an eraser tip cautery and just blanch all this. It's like you can make it chalky white, but it all grows back. And here you can see a choroidal hemangioma surrounding the optic nerve. This is why it's important to do a fundus examination in these children to better understand whether or not they have choroidal involvement, because that puts the child at much higher risk of developing choroidal effusions. And they can even have, massive choroidal effusions. They usually go away once the pressure normalizes. I've never, in my experience, had to drain a choroidal effusion in a Sturge-Weber child that I operated on, but it's not uncommon that you have to just wait it out for a few weeks for it to resolve. I even have a patient that I have a CT scan of. It was an interesting story. I operated on the child and ended up doing a primary Ahmed implant for a number of reasons. And then the child was quite young, and then was having a CT scan done or an MRI done for figuring out whether the brain was involved. And you could see on the coronal sections that the child had choroidal effusions in the eye that we did the implant in. And then when I saw the child again, the choroidal effusions were gone. So probably choroidal effusions happen more commonly, but are simply not witnessed. They're transient in these children until the pressure is stabilized. Aniridia is presentation. You're, I'm sure, all familiar with what congenital aniridia is. It's a PAX6 gene mutation that involves maldevelopment of the angle structures, and particularly the iris. And they can have severe glaucoma early in life, presenting at birth even. And they can often develop glaucoma on the basis of angle closure glaucoma, when this rudimentary stump of angle just flips up and occludes the anterior chamber angle. These children can also have foveal hypoplasia. They tend to have very small optic discs. They'll often have cataract, as was shown in that artist's rendering. And about 50 to 70% of children with aniridia will end up having a glaucoma or glaucoma concern by their teenage years. One of the things that we discovered in aniridia, we published this a few years ago. For those of you who know about pachymetry and the role of central corneal thickness in measuring intraocular pressure, I noticed in a child I was doing a goniotomy on with aniridia that the pass through the cornea seemed really, really long. And so I started measuring the corneal thickness in children with aniridia, and they were all in the 700 to 900 micron range, even if they were perfectly clear. So before our description of that, it was not recognized that in aniridia, the cornea is very, very thick. And I suspect that many children with aniridia have had unnecessary surgery because their pressure was consistently high, because you were measuring pressure on a 900 micron cornea. So the key to deciding on what to do in these children is based on the optic nerve and gonioscopy, not on what the pressure is, because you just can't trust the pressure. Future trends, I think circumferential trabeculotomy is going to become the primarily the initial approach in most situations, and we try very hard to spare the conjunctiva and do everything ab interno if we can. The benefits of the angle surgery is that it attacks the tissue where the disease is, and as I said, the ab interno approach spares the conjunctiva and leaves you more options for later on should the angle surgery fail. The downsides here are that it requires a functional downstream collector channels. And so, as I said, we're probably going to be having genetic testing available soon to be able to decide preoperatively whether or not it's even worth doing angle surgery. Again, Y360, if you have cannulated the entire angle and you've treated the entire angle and it fails, you can then know that you just have to move on to something that creates a fistula rather than keep continually banging away at the angle. If it's not going to work and it was done properly, it's not going to work again. In 2014, Devinder Grover and Ron Feldman in Texas described something that they termed GAT, gonioscopic assisted transluminal trabeculotomy, which is a procedure in which we cannulate the entire angle from the inside without touching the conjunctiva. Here you can see a schematic drawing for what that involves. And here's an example of a GAT. I think this is an adult. Yeah, I'm pretty sure this is an adult. Again, I don't have this edited as quickly as I would like, but this is using that same catheter that you saw, but we're feeding it in through the cornea, and then using the gonioscopic prism, we're going to go in and open the canal for maybe a clock hour to create a small opening and essentially peel the trabecular meshwork down and create essentially a landing strip. See how when you peel it down, you get a little opening there. Oh, it blanked. Here we're putting it into the canal with some intraocular forceps. These are the reusable MST forceps, but I use these days the Grieshaber 23 gauge reusable ones, or not single-use ones. But now you can see that I'm feeding this catheter into the trabecular meshwork, or into the canal. And this procedure can take as little as 40 minutes, 30 to 40 minutes to do if you don't run into obstructions in the canal. Let me speed things up here a little bit. And in a moment you see, oh, here it is. So you can see that it's come through, and this is always reassuring when you see the light coming back. And now I'm going to grab the device on the outside. Yeah, I didn't center the microscope, but essentially we're pulling on the two ends, and essentially it's cheese wiring 360 degrees in order to open the canal. This is what the adult patient looked like the next day. And again, it's scary because they end up with a big hyphema, but it usually clears within a day or so. And that patient has done very, very well. In adults, we do this for any sort of primarily trabecular disease, so it works quite well in steroid-induced glaucoma, certain forms of uveitic glaucoma, and pigmentary and pseudoexfoliation types of glaucoma, where we are pretty sure that the problem is in the trabecular meshwork. And so by doing this, we open up the angle. And I've had some remarkable successes of patients presenting, say, with chronic steroid-induced glaucoma with pressures in the 40s and so on, and we get them down to the teens. And it's especially gratifying in somebody who doesn't have much optic nerve damage but has some, and we can really stabilize things. I interrupted you. What was your question?
I was going to ask, why is this sort of procedure done more often in adults?
So why is this procedure not done more often in adults? Some people do advocate for it. There is some evidence from Dr. Grover's studies as well as others that show that that if glaucoma has been present a long time, it doesn't work that well. And the assumption or the working hypothesis for this is that the collector channels have also been damaged over many years of glaucoma. So it's thought that opening up the trabecular meshwork isn't going to help the downstream problem. So it's probably a good procedure. It is a good procedure in children. It is probably my go-to procedure and the primary procedure in juvenile open-angle glaucoma, where the damage is primarily localized to the trabecular meshwork and the downstream system is still intact, and also younger patients with exfoliation, pigment dispersion, and so on. But primary open-angle glaucoma with severe visual field loss, it tends not to work. And I've had to do, when I've tried it on more than one occasion, I've had to go back to the operating room the next day or two because of super high pressures and do a tube or a trabeculectomy. So I've stopped offering them in patients older than 50 or 60 unless they have a very mild disease that needs to be treated. We now do this in pediatric procedures. I think I have, this is a GAD in an 8-month-old with primary congenital glaucoma. Again, let's see, I don't remember how, this is 3 or 4 minutes long, so let me get to the, so here I'm feeding the device in, and the same maneuver that you just saw. One of the problems with this device, though, is that it's a little short for a ophthalmic eye. It has a wider part of the catheter than a thin part that is designed to go into the trabecular meshwork. And if you do the math of 2 pi r for what is the circumference of the eye with a 15 millimeter cornea, the catheter is about 2 centimeters too short. So you actually have to feed it all the way into the eye and do some modifications in young children. I do, and this is what it looks like after you've opened up the canal. Really pretty and very nice. The other alternative to GAT is something called the Trab 360, which is replaced by something called the Trab Omni. And this is one that we have very high quality video because this was done on this plane in Hanoi a number of years ago. So you'll recognize the operating room, and I guess this is the old plane because there were windows in the operating room. But this is a device that allows you to go in and through a single incision I make a second paracentesis primarily to make it easier to remove the viscoelastic. Here we can see the angle. This is a slightly older child with late presenting congenital glaucoma. And this is the device. The handle has a little scroll wheel where you can deploy a a proline or a nylon suture right into the angle and then use it to tear open the meshwork. And here in a second, you're going to see and so now that I've used that metal device to enter the trabecular meshwork, I then start using the scroll wheel on the device to go into the anterior chamber, into the canal. And you can see blue starting to go around. And again, in the interest of time, I'll show you what we do afterwards. And so now I can start pulling things back and using this device to essentially 180 degrees tear open the trabecular meshwork over 180 degrees, or nearly 180 degrees. And then you wind it back and then flip over and go in the opposite direction. And essentially it allows you to do what's like a goniotomy, but almost the entire angle through a single incision. So here you can see we've created a beautiful goniotomy type cleft, and now I'm deploying it into the canal and doing the same thing in the opposite direction. I'm just going to speed things up here. And we're done. And this child was on the Flying Eye Hospital when we did this procedure. So I will. So I really do think that circumferential trabeculotomy is going to be the standard initial procedure for managing childhood glaucoma. We have a number of devices, both available and in development, and we're going to try to spare the conjunctiva to be able to preserve options for later on should the angle surgery fail. So it's been my experience in much of Africa where I've worked that most congenital glaucoma is treated with trabeculectomy. And although you can get reasonable short-term results, trabeculectomies fail, and they're essentially bypassing the normal part of the outflow system. And the outflow system in that setting will atrophy. And after a trabeculectomy, often angle surgery doesn't work very well because the trabecular meshwork and the canal has essentially atrophied. So, summary, younger presentation is a poorer outcome. 50% of children are blind when they present at birth. Something in the air that's been bothering me today. Later presentation, much better prognosis. We can control the pressure in 85% of these children, but in one out of three, the vision is not good. And the reason for that is, excuse me, amblyopia. And so it's important when you're managing these children that you don't lose sight of the fact that, especially in unilateral disease or asymmetric disease, you need to pay attention to amblyopia, the refractive needs, the patching needs, or so on, or you're going to have sort of a half victory in terms of controlling the pressure but not preserving vision.